Hello, all. We're about to get started with this next session, which is entitled Her Impact on EHR, Women Innovators in Electronic Health Records Research. And with us today, we have four incredible speakers that I'm really excited to hear from. Dr. Sarah Lotspeech, Dr. Li Wang, Dr. Chuan Hong, and Dr. Rebecca Hubbard. And we're going to have four talks that are about 15 minutes each. And starting us off will be Dr. Sarah Lotspeech.
Great. Thank you, Ashley. I'm looking forward to hearing everybody's talks today and sharing some work we've been doing. Okay, so let me pull up my slides. And I accidentally jumped in the middle. Okay. So I'm Sarah Lotspeech. I'm an assistant professor of statistics at Wake Forest University in North Carolina in the US. And I'm going to be talking today about a collaborative project I've been working on where we're trying to operationalize a whole hospital, whole person health score in our electronic health records, despite the inevitable data quality issues. If you'd prefer to follow along with the slides on your own device, they're available on my website here. You can either scan the QR code or go there, but when it's Zoom, it's kind of nice and on your screen already. So I'll talk briefly about the motivation. There's an old adage, I believe attributed to Benjamin Franklin, that an ounce of prevention is worth a pound of cure. And this is very much in line with how learning healthcare systems are now transitioning from a reactive or treatment-oriented philosophy to more of a proactive or prevention-based one. And, oops. This transition is important because we're trying to prevent future healthcare utilization, and this works on two levels. So it improves health for the individuals. You could say it's maybe saving pain, and it's also providing cost savings to the institutions. You could also say that it's saving money. So having a standardized summary measure of whole person health could play a central role as we're trying to manage this transition, kind of a one number summary of how well people are doing, and maybe how that score can be related to an outcome like healthcare utilization that's really at the forefront of our interest in the learning health system. And so one such measure is the allostatic load index, or the ALI, which is a composite measure of whole person health. I believe it was first introduced in the 80s. And the idea is that instead of looking at maybe just one measure like systolic blood pressure, which could talk about cardiovascular health, or cholesterol to talk about metabolic health, you're bringing them all together. And so one example, if you were to look at 4 patients, we could combine 10 component stressors across the body, and we take their numeric values, and we can take 2 scores or stressors from cardiovascular, 3 from metabolic system, and 5 from the inflammatory system. And so the way a lot of these allostatic load indices are defined is that you take these numeric values, you discretize them at some clinically meaningful threshold, and you decide what value, for example, of a systolic blood pressure, would be perceived as stressful to the body. So then at an individual level, the allostatic load index can be either taken as the count of stressors they've experienced in their lifetime. So that first row has an allostatic load index of 1 out of 10, where that bottom row instead has an allostatic load index of 6 out of 10. And so there are a few versions of this allostatic load index, but the one that I'm talking about today was specifically proposed by Seaman et al. In 2001, and it's combining these 10 component stressors across 3 body systems. And so it is a nice one number summary, and it has been validated to some degree, but it was primarily used in the past in controlled clinical settings, which means that every patient had every measure. Now, if we're trying to operationalize it in the electronic health record, that's just not reality. So we have 2 main types of data quality issues within the electronic health record. The first, if you were to consider an example data point of a patient's hemoglobin A1C of 5.2%, there is one big if of if they even had a hemoglobin A1C measurement done. So when I extract data from the EHR, this particular patient might not actually have had it measured, so I'm not going to know that. Also, due to maybe some data cleaning algorithm or data entry issues, it's also possible that even if it was measured, what was measured is not actually what's correct. And so different reasons for error exist. A few examples are like a data cleaning algorithm, like I said, device imprecision, just from things that like blood tests and assays, or data entry error. And you can then hopefully correct this data entry error. If I were to go into the original, maybe Epic or patient chart, I might be able to find that, oop, that number got transposed along the way. And I can recover the fact that that should have been a 5.2% hemoglobin A1C. And so this error mechanism is going to relate the version of the hemoglobin A1C in the extracted EHR to what's actually kind of existing in the patient's original source chart. Then there's also these missingness. This could be for a lot of different reasons. They could be presumed healthy, so we didn't need to do it. Maybe their insurance wouldn't cover it. Maybe they didn't consent. And so there's this other mechanism of it being missing. And what we were trying to do was see if we could kind of enrich our extracted EHR data by trying to combine how we think these, basically, like, can we fill in the missingness a little bit? Can we try to figure out who would have been presumed healthy and so they didn't need their hemoglobin A1C done? And so we tried to do this kind of twofold audit where we were trying to validate things that could have been, that were not missing, but could still have been error prone. And we were also trying to see, well, they didn't have a measurement, but they don't have any contraindications to say that they would have had an unhealthy hemoglobin A1C. And we tried to pull in some auxiliary information that way. And so validation studies like this are really valuable, but they're cost and time and money expensive undertakings. And so there's two key opportunities as the statistician on the project to kind of make the most of our investment. The first is in the design. It's choosing which people I'm going to actually validate, because you can't often choose all of them. And some people are simply more informative than others. And the other is, at the end of the day, how am I actually going to use these data for my analysis? Oh, and these concepts are intertwined. So just to briefly talk about the analysis, I considered two different versions of the allostatic load index. Suppose that their underlying health, their true allostatic load index, is the sum of these 10 component stressors, S sub ij, across for a given patient. So the true allostatic load can be between 0, meaning you have none of the stressors, and 1, meaning you had all. Now, the error-prone version is slightly modified. You now have error-prone stressors that were actually observed, but we also have this indicator of missingness, because it now needs to be observed not as like the number of stressors in your chart divided by 10, because that's going ahead and assuming that if it wasn't measured, it was negative. So instead, our error-prone version is the proportion of non-missing stressors that the patient had observed. And so we use a semiparametric logistic regression model that allows us to do the logistic regression model for healthcare utilization that we're interested in, which is our log odds of engaging in the healthcare system at least once in a 2-year period. And this is broken down as a function of the allostatic load index and some additional covariates like age that are thought to be related. And now the semiparametric approach allows us to also capture the errors relating the true allostatic load index to the error-prone version and the other additional covariates. We're allowed to leave that unspecified. So this is nice for our robustness. I don't have to specify an additional model here. And so for the validation study, technically speaking, anything that doesn't validate the missing at random assumption is fair game, which means I can choose my validation subset based on anything that's fully observed. So the most, I guess, the least informative thing to do would be to just take a random grab of people from the electronic health record. Since we have a binary outcome, you could also stratify on the outcome. So I could take half of my validation set from people who were engaging in the healthcare system and half from those who didn't. Or I could simultaneously stratify on the outcome, healthcare utilization, and some stratified version of the allostatic load, maybe above and below the median. And I could take then balanced versions from the different strata, or I could actually choose different stratum sizes to achieve kind of an optimal or lowest variance situation if I desired. However, any of these stratified approaches are kind of losing some of the granularity of the allostatic load index. So for us, we found that more of what's called an extreme tail sampling design, where you're basically ranking everybody and then choosing people at the extremes, was the most helpful or the most informative. And so we fit the naive version of our logistic regression model. So I fit the model for healthcare utilization on the error-prone allostatic load and the additional covariates. I used that model to get residuals. And then I took half of my validation set from the people who were not engaging in the healthcare system, but the model thought they really should have been, and the other half from people who didn't engage in the healthcare system, but had a high predicted probability to do so. This interpretation is just specific to the logistic regression model. at the end of the day, I am taking the largest residuals at both ends of the extreme. And so our actual data were a sample of 1,000 patients from Wake Forest Baptist Atrium Health in Winston-Salem, North Carolina. Sorry, I can't get my picture of people is in the way, so I can't see the slide. So the EHR had all of the variables that were relevant, but again, they are prone to missingness and errors. So we set out to audit 100 of our 1,000 people, and we broke our 100 people audit across 3 waves. The pilot was only 4 people, and we did this really just to let our auditors get accustomed to the protocol, and this was kind of a first pass. We had built some tools, we wanted to see how they worked. We also used this pilot and had all of the auditors look at the same variables so that we could then do a measure of like inter-rater agreement, so that down the line, when they're only auditing one or the other, we can argue that they're kind of working as a team interchangeably. We then chose wave 2 on that kind of balanced stratified design because we really didn't have enough information to do anything more severe quite yet. We didn't know how good our naive analysis would be. And then the final wave we did end up choosing in this residual sampling type approach. So the design adapted with us all along the way. And so we can describe a little bit what we found from the first 2 waves of the audit. So the light pink means that the value that we extracted from the EHR was correct. The dark red means that it was incorrect. This didn't happen all that often, but there were a small number where what we found in like the original epic didn't match what was extracted. This pink finding was kind of surprising. These were variables that we got in the extracted data that we couldn't then find when we went back into epic. And that actually provided a really important opportunity to chat with the data warehouse people and understand kind of what's happening as those data get extracted. And then these 2 shades of like teal, I guess. So the light teal are instances where those are pretty rare lab values on the upper left-hand side, like creatinine clearance. But our clinical team was able to provide some kind of guideline of if this person has this diagnosis in their chart, they probably would have had like a healthy or an unhealthy creatinine clearance relative to the threshold. So those shades of teal are actually missing data that we were able to recover through the validation. And so based on the first 2 parts of the audit, so based on 1,000 people's unaudited EHR data and 52 people's audited EHR data taken all together, we fit our model of healthcare utilization and the allostatic load index, adjusting for age. And so the 2 comparators I have here in the teal is the naive. So if I just use the extracted ALI from the EHR and didn't worry about the fact that it has errors and missingness. The light pink is the complete case. So this is using only my validated subset of 52 people, throwing everybody else away. And then the dark pink is our semiparametric logistic regression that's trying to capture the best of both worlds. So we're using the 52 people that were audited, and we're using everything we can from the remaining people. And so the models agree on a number of things. So they agree based on the intercept that there was a low expected odds of hospitalization or ED visit, so low odds of engaging in the healthcare system to begin with. The naive and semiparametric approaches agree that older patients were expected to have higher odds of engaging in the healthcare system, which I think is consistent with the literature. And then the allostatic load index in that rightmost panel is where things maybe start to deviate a little more. So we see that the higher allostatic load index was associated with higher odds of engaging in the healthcare system, which is consistent with the literature. But we find that the validated association, so focusing just on the dot in the complete case analysis, was stronger than the naive or the SMLE. So that's actually an odds ratio of 1.35 relative to the naive, which was 1.03. And our SMLE seems to fall somewhere in the middle, where the point estimate is getting some of that higher magnitude or larger magnitude from the validated data, but it's recovering more efficiency by including everybody else. And so at this stage, we then used the pilot and wave 1, and we did kind of what we call bespoke simulation studies. And we wanted to look at how we should design the last part. So basically, the different lines are different designs. The x-axis is different error settings, but the main takeaway was really that under low error rates, and so 99% true positives or 95% true positives, residual sampling was the most efficient by far. That's that dark brown line. Only when you get to these like 80% true positive rates, does the residual based on the naive kind of drop below? And our error settings were really falling in that kind of those ideal settings to the left. So we did decide to design wave 2 with the residual sample. And so just to wrap up, the allostatic load index is a composite measure of whole person health. It could be used to predict healthcare utilization, which is of interest in the learning health system. And we have a version of the data to do it in the EHR, but there are quality issues that we need to contend with. And so targeted partial validation of the EHR can be a nice way to enrich what you've extracted by going back to kind of the source and finding additional stuff through your clinical trainees. And there are important statistical opportunities to promote efficiency and robustness through the way that we design the validation study and then the way that we plan our analysis. I'd like to acknowledge our funders, collaborators, and the computing resources. And I would be remiss if I did not plug our master's program at Wake Forest if you're interested in a small collaborative cohort. I know Ashley can maybe vouch for this, but we are holding an open house soon and would love to see more applications. These are my 3 references, but that's it, and I'm at time. So you can drop questions in the chat if you have them. Thank you.
Thank you so much to Dr. Lotspeech for such a wonderful and interesting presentation. And yes, I can concur. This is a wonderful master's program. I'm a recent alum and have nothing but wonderful things to say about them. And next up on our program list is Dr. Li Wang, and you can take it away. You are muted with your camera off. We can't hear you or see you, but we can see your slides. There we go. Still muted.
Muted. Hi.
There we go. We can hear you.
Hi, everyone. My name is Lo Wang. I'm an assistant professor in the Department of Math Stats and Data Science at Loyola Marymount University. Today, I'll be talking about developing well-calibrated risk prediction models using biased EHR data. The electronic health record data are usually collected for clinical reasons, not for research purposes. Therefore, to build risk prediction models using EHR, some important risk predictors might be missing. Therefore, to enhance risk assessment using EHR, researchers often enrich predictors from external sources. To evaluate the added value of the external risk predictors, we compare models using only EHR to those including both EHR and the external predictors. For example, to assess the risk of breast cancer, the conventional risk predictors such as age at first live birth, family history of breast cancer have been well validated in the breast cancer risk assessment tool for the entire US Caucasian women, which is referred to as the target population. But additional biomarkers such as percent mammographic density are only available in Penn Medicine Biobank, which is referred to as the external source data. So our question here is how to incorporate these new predictors from the source data into the existing risk prediction model for the entire population if the source data do not represent the target population. We face challenges because the target population source data may have different sets of predictors, different marginal distributions of these predictors, or even different underlying relationships between the outcome variable and the predictors. Just simply ignoring such discrepancies could result in biased evaluation of the new predictors. To address this issue, Cao and colleagues developed a constrained maximum likelihood approach. They use it to develop a risk prediction model incorporating both standard and new predictors. It ensures good calibration of the model in a target population using some constraints, and it does not require an independent validation sample. I'll first walk you through the data structure here. So we have individual level source data where Y is a binary outcome with 1 indicating a case, 0 a control. So here case refers to developing breast cancer within 5 years of a negative screening mammogram. And the X are the standard risk predictors, Z are the new candidate risk predictors, and altogether they form the source data. And we only have some summary level data for the target population. For example, the distribution of the standard predictors X in the target population denoted as delta X is known. And the base model phi X that we can use to predict the outcome using only X is well calibrated in the target population. So the constraint maximum likelihood method allows the target and the source data to have different sets of different distributions of the standard risk predictors in X, and even different regression coefficients that define the underlying relationship between the response variable Y and both X and Z. However, it assumes that conditional distribution of the new predictor Z given the standard risk X is the same in the target and the source population. And we use a parametric function f tau to model this conditional probability. Okay, here is how it works. So first we consider a working model to predict Y using both X and Z based on a regular logistic regression model. Then we form the log likelihood function for the observed data. So here the marginal distribution of X is irrelevant and also considered known, so it's dropped out of the log likelihood function. Then we maximize the log likelihood function subject to constraints that force the working model to predict as well as the base model in the target population. So how do we construct the constraints? First, we categorize the predict risk by phi X into I intervals. Then within each risk interval, AR to BR, we define the average risk by P sub R, and then the superscript E here indicates that these probabilities are calculated externally to the source data we use to fit the working model. And then we express the constraints as below. So the first term here is the average risk calculated based on a working model. And then we want this risk to be very close to the well-calibrated risk based on the base model phi X. So the difference, for example, is less than 10% of these well-validated probabilities. So D here is a vector of positive numbers to define the tolerance of difference. So in my simulation studies, I used the 10%. Okay, so the constraint maximum likelihood method ensures good calibration with some information available about the target population. The good calibration here refers to the agreement between the predicted risk and the observed outcome incidence. However, this is only half of the story because good calibration does not necessarily inform a model's predictive accuracy, which is usually measured by the area under the ROC curve or the positive predictive values, true positive rate, and so on. It refers to the ability of a model to differentiate cases from controls. McIntosh and Pepper showed that the greatest possible predictive accuracy measured by AUC was achieved when the working model is actually the true underlying model that relates the response variable to all the predictors. However, the reality is we don't have a source data that will represent the target population. The working model is not the underlying true model. And then our goal here is still to evaluate the added value of the new predictors. Then the question here is, while maintaining good calibration, how can we further improve CML for greater predictive accuracy when we evaluate these additional predictors using the biased EHR data? One thought is that maybe we can choose a subset from the source data that resembles the target population more. And then the propensity score matching approach in observational study sheds some new light on this study. Propensity score matching is a statistical method that's used to reduce the selection bias. It's used to estimate causal effect of a treatment by comparing treated individuals to untreated ones. propensity score is defined as the probability that an individual received the treatment given their observed characteristics. So it's usually estimated using a logistic regression model. And then people match treated individuals with untreated ones who have a similar propensity score. And then in the end, the matched groups have similar distribution of covariates. So here we do want a similar distributions of the data between the target population and the source population. And this is where we got our inspiration. So first, we need to assume that individual level data are available for the target population. And then we treat the source data as a biased sample from a combined population, with the target population being unsampled data. Then we define the propensity score here as the probability that an individual is selected into the source data from the combined population. Then we want to match individuals in the target population with source data who have very similar propensity scores. And to achieve the goal that the matched source data have similar data distribution as the target population. So here's the sampling scheme. First, we create an indicator variable R with 1 indicating it is a source data, 0 if it's target population. And we fit a logistic regression model on the combined data, including both target and source data, to relate the sampling status to the response variable Y and all standard risk predictors X. And then we calculated the propensity score based on this logistic regression model for each observation. And then usually the target population is much larger than the source data. Then we want to select a random sample of n observations from that target population, and then match each of them with a source unit who have the closest propensity score without replacement. And in the end, we fit the logistic regression model, including both X and Z, on these and match the source data using the CML method. Here's a simulation study I used to evaluate the effectiveness of the propensity score matching scheme. So we considered 4 X variables here. For example, the first one is age at first live birth. And we have 4 categories here: less than 20, 21 to 24, 25 to 29, and greater or equal to 30. And these are the probabilities for each category. These parameters are selected to mimic the distribution in the target population in the breast cancer study. Z represents the new predictor. For example, the percent mammographic density. It follows a truncated log normal distribution at less than 0, where the mean of the normal distribution is a linear combination of all the X variables. This is where the conditional relationship or conditional distribution of Z given X comes into play. And then I considered 3 scenarios. I'll focus on 2 and 3 today. So in both 2 and 3, X have different distributions. So these are the parameters we chose for these 2 scenarios for the 4 X variables. Again, these parameters actually mimic the distribution for the Penn Biobank data. In scenario 2, for the underlying logistic regression model that relates Y to X and Z, only the intercept is different. So it simulates a scenario where the prevalence of the cases differ between target and source data, while in scenario 3, all regression coefficients are different. So we use the sample size 2000 in our simulations. The first column here are the true parameters. So these are the parameters in the logistic regression model we are interested in, and these are the true values of them. Here we compare the constrained maximum likelihood method using propensity score matching or just random sampling from the source data of these 2000 observations, and then compare them to the naive MLE, where we just treat the random sample from the source data as a sample that represents the target population. So you can see that the naive method cannot correct for the bias for the intercept. -2 is actually just the true intercept for the source data only. CML can correct the bias in the intercept here, and compared to random sampling, propensity score matching actually have very small bias, or the difference between the estimates and the true values are very small. And then here's the result for scenario 3. This is the more challenging scenario where the constraint maximum likelihood method alone cannot really reduce the bias by a lot. But if you look at the percent difference for propensity score matching, all these differences within 10%. So PSM propensity score matching can effectively reduce estimation bias when the source data deviates from the target population by a lot.
1 minute warning.
Oh, okay. I just take a further look at some of the data to try to get some more insights on propensity score matching. So this is the propensity score distribution for the target population, and you can see it differs from the source data. But after matching, the matched source data actually represent the target population pretty well. There's the comparison between the target population distribution and the matched data. So you can see all these distributions are very similar. For the matched data, for the source data, for example, these 4 probabilities actually were 5%, 16%, 56%, and 23%.
In the interest of time, I'm going to have to cut this off here. Thank you so much for a wonderful talk.
Yeah, thank you.
Our next speaker will be Dr. Hong.
Can you see my screen?
Yes.
Yeah. Hi, everyone. My name is Chuan Hong, and I'm a faculty from Duke University, Biostat and Bioinformatics. Today, I'm very glad to be here to share with you a topic that become more and more interesting recently. So that is how to evaluate generative AI specifically generative large language model in healthcare. And this presentation will summarize the findings of our recent scoping review and also our newly developed evaluation pipeline. To set the stage, I will begin with a brief introduction on the example use cases of LLM in healthcare. Then I'm going to dive into 2 types of evaluation methods, including qualitative evaluation and also quantitative evaluation. Lastly, I'm going to talk about how this diverse evaluation strategy can be integrated and tailored to healthcare applications. So the major application of LLM can be roughly stratified into 3 categories, including text summarization, question and answering, and also chatbots. For text summarization, LLM generates abstract summarizations, for example, patient discharge note. For question and answering, LLM generates answers to questions based on the context provided or from the knowledge they were trained on. And also for chatbot task, LLM have already been significantly used to enhance the interaction between clinicians and patients. So the figure on the right-hand side describes 10 use cases for medical professionals and also 10 use cases for patients from a recent paper published by NPG Digital Medicine. So given the rapid potentials and advancements of LLM, it is very important to rigorously evaluate their performance. However, based on our scoping review, while there are many reviews in literature talking about LLM, most of them are focusing on their development and applications, while very few of them focus on the evaluation and the metrics for LLM. And also among those few studies, there are some notable research gaps. So first, there is an absence of a framework that integrates both qualitative and quantitative evaluation method. Second, there is no clear guidance on how to conduct real-world evaluation in the healthcare setting. So about our work, our contribution has twofold. First, we provide a broad overview on the latest evaluation methods for LLM, and also our work can serve as a go-to menu to help users to identify the evaluation method they need for their specific use cases. Now I'm going to talk about our proposed evaluation strategy. This figure is our main figure, which illustrates a comprehensive evaluation strategy for LLM. As you can see from this figure, the middle part is LLM, which is the target of this evaluation. On the left-hand side is the qualitative evaluation, which employs human judgment. And on the right-hand side is the quantitative evaluation. So while the quantitative one also rely on human judgment, it is mainly focusing on automatically and objectively compare the AI-generated text. We call that hypothesis text here, versus the human-generated text. We call that reference text. And as you can see, there is a double-sided arrow between the two evaluation blocks, indicating a dynamic interaction between the two evaluation methods. I'm going to talk about each of these blocks in details in the next few slides. So first, let's look at the qualitative evaluation. Here are some key components of the qualitative evaluation. First, it primarily relies on human judgment, and it moves beyond measurable parameters to evaluate the more subjective aspects. In the most of the LLM evaluation work in literature, investigators, they directly adapt or partially adapted the so-called multidimensional quality metrics framework, which was originally proposed for old translation task. And this framework categorized type of criteria into linguistic quality, efficiency, content integrity, trustworthiness, and also usefulness in the LLM outputs. For example, for linguistic quality, it includes aspects such as fluency, coherence, clarity, and brevity of LLM outputs. For efficiency, basically, we need to evaluate the ease of integration and also the speed of generation. For content integrity, it covers the accuracy, the completeness, and also relevance to ensure the content generated by AI is accurate. And also for the application in healthcare system, trustworthiness is also very important, which addresses the important ethical considerations in AI. And finally, practical utility. This aspect evaluates the real-world application of LLM outputs, ensuring that they are relevant and also effective in practice scenario. And for each of these evaluation criteria, there can be different methods applied, and which usually include case studies, expert review panels, rubric-based evaluation, and also scoring system. So for case studies, it offers in-depth analysis of specific examples of LLM, providing very important insights into the real-world application. So for expert review panel, it often involves healthcare professionals, which provides comprehensive feedback and also analysis from experts on the LLM development. For rubric-based evaluation, usually it employs detailed checklists or guidelines, which are suitable for scenario requiring very rigorous adherence to specific standards. And also there is scoring system, which quantify the descriptive judgments of LLM outputs into numeric values for model comparison. So now I would like to talk about quantitative evaluation. So different from qualitative evaluation that is purely based on human judgment, the quantitative evaluation utilizes the computational tools to assess the performance of LLM automatically. So this type of evaluation is designed to provide more objective and reproducible metrics. These metrics often analyze the degree of similarity between the AI-generated text and also the human-generated text, and regarding their contents, phrasing, and also meanings. The figure below is an example of how to compare the similarity between two sentences, one written by AI and one written by human. So there are a lot of different ways of doing that. Basically, they just compare the overlapping, the similarity between these two types of contents. So one big challenge users face is there are too many quantitative metrics in literature. So like a lot of users, they just randomly pick up one for quantitative evaluation. And to deal with this challenge, we have organized these metrics into a taxonomy that categorize all different metrics by different aspects. And this can help users to identify the most suitable metrics for a given application. So as you can see in this figure, our taxonomy includes several dimensions. And so we can categorize those metrics by method perspective, and also we categorize those metrics by function perspective. So for the method perspective, it includes like level of granularity. We can categorize those metrics by how granular the information they evaluate. And also, we categorize those metrics based on if they use human reference or not, or if the evaluation need to consider the contextual information or not. Like for function perspective, so we consider the content veracity and also the trustworthiness. So I will now dive into the detail for this, given the time limit. And now I want to talk about a more interesting content. So that is how we actually apply these evaluation metrics in real life. I think most of the audience, you may already know what is EPIC, right? That is the EHR system widely used by United States. And there is one function in EPIC that named as in-basket, so which is an electronic messaging system designed to help clinicians to communicate within each other or interact with between clinician and patients. So recently, there is a new AI feature for in-basket, like basically they are developed based on ChatGPT. So to categorize incoming messages from the patient and also to generate draft reply to the patient automatically. So a lot of institutions have already started using these new AI features, but there is no formal evaluation for those features. So what we have done is we apply our evaluation metrics to evaluate those new AI features. And as you can see on the left-hand side, so we have collected our data set to enable this evaluation. Those data sets are essentially a message pairs. So we have the original patient messages. We also have the AI drafted replies. And finally, we have the clinician's decision on if they want to use this draft or not, and also their edits on top of those drafts. And as you can see from this table, so these are our comprehensive evaluation applied to this data set. In the middle, these are our evaluation aspects. So include metrics like fluency, clarity, relevance, and also toxicity. So for each of these aspects, we design a scorecard. So that are questions which are clinician friendly. So we transfer those aspects into some questions that can be easily understood. So like we want the clinician to assign score for each of the question based on the performance of the AI generate tasks. Like
1 minute
if
warning.
they think, okay, if they think this message is hard to read or understand, and corresponding to each of these aspects, we also have our automated metrics on the right-hand side. And these slides show the results from our evaluation. So we also categorize those messages into different buckets. As you can see, so the agreement between human evaluation and the quantitative evaluation are very high. And also we identify some area need to be improved for this AI feature. For example, most of the error happens for like missing critical information. So that is because when AI generate message, they only look at the patient income message itself without considering the context. Okay, so that is the end of my talk. Thank you so much for your attention and happy to take any question afterward.
In the interest of time, we can push all questions to the end of this session. I'd like to thank Dr. Hong for a wonderful presentation. And last but not least, we have Dr. Rebecca Hubbard. Take it away.
All right. Thank you to everybody for sticking around until this last talk. Let me see if I can full screen this. So I'm going to talk a bit about some projects that I've worked on with some really fantastic doctoral students and postdocs, investigating different ways that we can use EHR data and account for some of the messiness and error that we've heard about earlier in this session. And the thing that I'd really like to highlight is that these data did not just drop out of the sky. They are not just like any other longitudinal observational data set. They were generated in a specific way because of the way that humans interact with the healthcare system. And so I think it's really important that we as data scientists and statisticians take a really active role in using our lived experience with the healthcare system, our understanding of the scientific context, to make sure that we're using the data in the most valid way that we possibly can. So we already heard a little bit in this session about the learning healthcare system. If that is a new concept to you, the learning healthcare system is sort of this virtuous cycle whereby the system that delivers clinical care to patients records lots of facts about the health of those patients and the treatments that they're receiving, and that generates an enormous electronic database that we could potentially use for research. So if we take that database and we use it to study which treatments work best for which people, we can generate new evidence about the relative effectiveness of different treatments, which we then roll back into clinical practice, which generates more data that we can then use to generate new evidence, to learn more, which goes back into practice, and so on and so on. So this is a very popular idea right now. There are a lot of healthcare systems that are trying to put this into practice, and there are a number of different barriers to it. But I think when statisticians and data scientists engage with the learning healthcare system, a lot of times we see ourselves as contributing in this evidence generation phase. So we get the data, we're sort of passive receivers of the data. We take it, we run our analyses, we generate results, and then we hand them off to the clinicians and healthcare decision makers. So what I would like to do with this talk is just raise awareness of the importance of contributing in a really active way, not only to that evidence generation phase, but to understanding of the data, using our knowledge of the scientific context, using our knowledge of the healthcare system to make sense of the data, and make sure that the analytic approaches that we're harnessing are appropriate. And then on the back end, not just to passively hand off results to scientists and clinicians, but to really understand how the research results that we're generating are going to be used to inform practice and what implications that has for the health and health outcomes of populations. Because depending on how our results are going to be used, the correct question to be asking, the correct study design to be using, the correct analytic method to be using is different. And so I think it's really important that we as statisticians and data scientists take an active role in this whole process, and don't just passively act like cogs in the machine, kind of turning the crank on R and doing the analysis. So as an example
Hey,
of
Rebecca.
how, yes?
Sorry, I think we're not seeing your slides as they move. We're only on the first slide.
Got it. You know, it's really funny. I always have this problem when I don't share my whole screen. I just share one window. Thank you for letting me know, because I've given like whole presentations without anyone pointing that out to me, which is not great. So hopefully you can now see slide number 2.
Yes.
Okay, thank you.
Great.
So here I'm illustrating what is called the informative visit process, which is one of the many ways in which EHR data do not quite resemble traditional longitudinal observational study data. So in this figure on the left, I have 5 hypothetical biomarker trajectories illustrated in different colors. And these are simulated data. This is not a real biomarker, but we're imagining here that these are 5 patients who have some kind of a biomarker, some kind of a biological measurement that varies over time. And if we were able to assess it every single day and track in real time how their biomarkers were evolving, it would look like the figure on the left-hand side here. So this is sort of complete information about the biomarker trajectory for a given patient. On the right, we have what this trajectory or these trajectories might look like if we used the EHR to extract information about them. So in the EHR data, we are not monitoring patients in real time. We only see them when they present to the healthcare system for care. And so we end up with this coarse discretization of the process where we only update every once in a while. And for some patients, we have more updates than others. Oh, and I want to mention, of course, that this is work by my former doctoral student, Joanna Harton, and have the reference on the bottom of the slide. So it turns out if we took those EHR-derived trajectories, we could decompose them into 2 different pieces. One piece that's going to come from what I'm going to call informative visits, and another piece from non-informative visits. So informative visits are visits that are prompted by the underlying biomarker itself. So let's say that this biomarker is some kind of a physiologic measurement that gets elevated when you're experiencing a disease flare-up, and therefore you have symptoms and you come into the healthcare system to get it checked out. In that case, we're going to tend to have more information about people when they're experiencing higher biomarker values. So if we look at just the information from informative visits, we see more detail about the part of the trajectory that's high, and we see very little or no information about the part of the trajectory that's low. On the other hand, fortunately, EHR data also includes information from non-informative visits. So people make visits to the healthcare system that are well visits, so annual checkups. There are standard follow-up schedules for all different sorts of conditions where people come in just to get checked out and see how they're doing. And of course, if we're interested in studying one particular condition, there's possibly going to be other interaction with the healthcare system that's not due to the condition that we are interested in. And so all of those interactions would also potentially present as non-informative visits. So in my hypothetical idealized trajectories here, everybody is very, very compliant. They all come into the healthcare system every 3 months. And so fortunately, I get this additional information that's this every 3 monthly updating of the biomarker trajectory. So if I take the information from the informative visits and the non-informative visits and I put it together, I'll end up with the total information that I observe in the EHR. Unfortunately, we don't have a good way to distinguish informative visits from non-informative visits. So there are various different things that we could look for in the electronic health record, like whether or not it was an emergency department visit, or whether or not you have a procedure code for an annual physical. But in general, we're not going to be able to distinguish these two types of information. So we need to have some kind of approach to analyzing data where the trajectories are contaminated with informative visits. So in work with my former postdoctoral fellow, Molly Zhang, she developed a taxonomy for this informative presence bias problem and decomposed the bias that arises due to informative visiting into two different sources. So if you think about those trajectories that I had on the previous slide, if we want to study the relationship between the biomarker and a health outcome of interest, there are two different ways that that's going to lead to bias. The first is differential and/or dependent misclassification of our EHR-derived biomarker. So those trajectories, whether we have informative visits or non-informative visits, are coarse. They don't completely capture the evolving information about the underlying characteristic of the patient that we wish that we had. So if we just naively use what information we're able to see, there's going to be a degree of measurement error in that observation. Additionally, a more pernicious and subtle source of bias in these analyses is collider bias that arises due to conditioning on utilization intensity. So this arises due to the fact that the amount of information that's available in the EHR is going to be different for every person, and the differences in the amount of information that's available are potentially going to be related to the underlying health conditions that we're trying to study. So I'm going to break that down for you in a quick example. So let's say we're interested in looking at the relationship between a health condition like diabetes and a health outcome like progression-free survival in cancer patients. So we'd like to look at the relationship between those two things, but because we only have access to EHR data, everything is measured imperfectly. So we don't have that true X and that true Y. Instead, we have misclassified analogs. If we think about the relationship among these variables that we're trying to study, we would like to assess this relationship between diabetes and progression-free survival, but instead we only have their imperfect EHR-derived analogs, and those imperfect versions are going to depend on our ability to ascertain them using EHR data, which we only capture when someone visits the healthcare system. So the quality of our representation of the constructs that we're interested in is going to vary depending on utilization intensity. People who touch the healthcare system more will have better classification of X and better classification of Y, which is a form of dependent misclassification. Additionally, the underlying constructs that we're trying to study, for instance, diabetes and cancer progression, also relate to utilization intensity, because people with more comorbid conditions are going to tend to touch the healthcare system more, and people who are experiencing a negative health outcome like a cancer progression are also going to have symptoms and are also going to touch the healthcare system more. And that induces differential misclassification of our outcome and our exposure. So an approach that's commonly proposed in the EHR literature to handle this is to just condition on utilization intensity. So essentially to get rid of this confounding by adjusting our models for how much someone interacts with the healthcare system. But unfortunately, in this complicated setup, conditioning on utilization intensity results in collider bias because it's caused by both the underlying X and Y that we're interested in. That induces a new bias, and so we've actually made the problem even worse for ourselves. So as an alternative to that, Molly proposed a sensitivity analysis or quantitative bias analysis approach in which we're able to recreate unbiased estimates of the underlying relationship between X and Y by using a predictive value weighting approach. So basically what we need to do here is take our data, replicate it 4 times. So each observation becomes 4 observations, each of which is assigned one of the 4 possible combinations of true values for X and Y. And then we weight each of those by the probability that the individual actually experienced that X and Y, conditional on their observed X, their observed Y, their utilization intensity, and covariates. Unfortunately, in practice, all of the classification accuracy parameters that we need in order to do this are typically unknown. So what we proposed was to use a sensitivity analysis type of approach where we would vary all of these characteristics, the sensitivity and specificity of X and Y, each conditional on utilization intensity across a grid of values, and see how it impacts our inference. So in this example, we observed a small positive association between diabetes and cancer progression or death. And when we conducted this sensitivity analysis, what we observed was that that conclusion was largely robust, and only under really unrealistic scenarios for the relationship between X and Y did we observe anything different. So just to wrap up, my overarching point is when we're conducting these types of analyses using EHR data, we need to take what we know about how the data were captured, how we interact with healthcare systems, in order to approve our analyses. And my goal really is to have us as scientists controlling the data that we're using, controlling the tools that we're using, rather than allowing them to control us. So again, I just want to challenge everyone to take a really active role in this kind of research. And I will say thank you to the organizers and to Ashley for chairing.
Thank you so much for an incredible talk. And thank you to all 4 of our speakers. If you are still here and would like to turn your camera on for a quick screenshot celebrating our performance together, we could take 30 seconds to do that. All right, 3, 2, 1, smile. Okay, and thank you so much. And I guess we get kicked to the keynote now.